Jonathan, and I want to move slightly into understanding kind of the diagnostic experience and barriers to diagnosis. So if I can stay with you for a moment, Jonathan, from your experience of working with the community, what are you hearing? What are the primary barriers to that early, really important early diagnosis?
Of course, yeah. So I think, like with many rare diseases, obviously, as we've seen in the England Rare Disease Action Plan and the developed nations, there's a lack of knowledge about rare conditions and specifically IMDs among healthcare professionals and the public themselves. Because through speaking to our communities, people actually only know about inherited metabolic disorders when they've got that diagnosis. It's like, right, I've never known about this in the past. I need to learn everything about it and they're just thrust into that world. And it's the same for healthcare professionals. Rare conditions at the end of the day. So how can you think to diagnose someone unless you've got that consciousness about it? So it's like, as a patient organisation, what we try to do is educate healthcare professionals. And then there's obviously what you need to think about the diagnosis and stuff like that is the non-specific symptoms. So as the saying goes, it's doctors are taught to think horse, not zebra. So, for example, a lot of them will have non-specific symptoms. So, to take a specific example, as we're running the Think Ammonia campaign at the moment, so hyperammonemia, it's a condition where ammonia levels in the blood are elevated, and that can cause serious neurological conditions such as brain damage, seizures, disability, death, and even. And that will, when people present to A&E departments, they will be screened for sepsis, meningitis, and everything. And it's a last kind of thought is maybe you should just test for ammonia. And then it's like everything sort of falls into place. So I think it's just that knowledge and the non-specific symptoms. And then obviously if we add more knowledge about IMDs and neurological presentations as well, we may be able to address that diagnostic odyssey, which can be between 5 to 7 years, and that's largely influenced by that lack of knowledge and also disbelief. So because people aren't taught to think about it, people will sort of maybe be less inclined to sort of listen to patients if they think I've got got that rare disease. We've actually had sort of someone respond to the Thought into Action sort of project, and they said they had to basically advocate for themselves over many appointments, and they finally went, okay, let's just do a test. And it came back that they did have that inherited metabolic disorder. So it's just like sort of education, I think.
So what role can an organization like Metabolic Support UK do to kind of help with that? Because, as we hear over and over again within rare disease, often the biggest barrier is that being believed or having the priority of those symptoms being actioned on. So, what role can you play in trying to kind of combat that?
That's it. So obviously, just to go back to the example of the hyperammonemia sort of example, because that is such a immediate threat for people if they are presenting with those symptoms, you need to act fast. So what we've done as part of that is we've developed a range of posters. So they will be displayed in healthcare settings across the UK. And that tells people how to think. So basically how to spot hyperammonemia, how to test for it and how to treat it. We've done a QR code that links to our website, and then that's got the guidelines that are up to date at the moment for the treatment of hyperammonemia, and that can help and just get that into basically healthcare professionals' minds. And we've also developed some sort of patient-facing information as well. So obviously, it's not something you think about. It's not something that a lot of people have heard about until they've got that diagnosis. So beforehand, it's like if you are experiencing these recurrent seizures and things like that, we've had it in the past. So I've spoken to a member of our community and their child was consistently having seizures and things like that. And they were investigating all different avenues. And eventually they found out that it actually was hyperammonemia. Just as a sort of a last protocol. And like they said, because they've had this for so long, they kind of gotten used to those high levels of ammonia in the blood. So there's a lot that patients' organisations can do to raise that awareness. And I think in the fact of the hyperammonemia campaign, that's what we're doing. And it's something that we're going to continue to do for other conditions and just more widely to sort of increase that profile and increase the awareness.
Brilliant. Thank you, Jonathan. And I really commend you guys. I know you do a huge amount of work, across all levels of policy and, just really try and drive that. So thank you for everything you do in this space. And Hannah, of course, for you, this is really personal. This is a lived experience for you. So can you sort of talk us through what your family's experience with your daughter was in terms of how you obtained a diagnosis, what that looked like for you as a family?
Yeah, so listening to Jonathan, I was like, yep, yep, yep. Went through all of that. So my daughter Tilly has a condition called guanidinoacetate methyltransferase deficiency, which is a creatine deficiency. Um, Getting her diagnosis took 5 years, and it was the most frustratingly difficult thing I've ever done in my life. Her condition developed over the first 2 years of her life. It became more and more noticeable that she was not developing like her peers. So I would take her to the doctors and I would be told, you're just a first-time mum. You just need to find something else to worry about. Then she was diagnosed with mild developmental delay, and then it would go on to moderate, and I would be asking for these referrals to various places and they would get declined. It was long waits for appointments, endless blood tests that took months and months and months to come back. Her community team got quite fixated on her having a degenerative neurological disorder, so they tested her for Rett syndrome quite a few times because her epilepsy was uncontrollable and just wasn't responding to any drugs at all. So she was just regressing and getting worse and worse and worse. And it had gotten to the point that I was told, look, she's not going to be able to walk for much longer. Things are getting worse. So I had my house completely renovated. I moved her bedroom downstairs. I got ready for her to become wheelchair bound again. And it was just constantly knocking on doors, shouting the loudest. I made myself such a nuisance for years. And I found out from a friend who was part of the SWAN UK group, so Syndromes Without a Name. And she told me about the 100,000 Genome Project. And Tilly's blood was sent off after, I think I asked about it about 5 times and was adamant she needed to be on it, but kept being told no. But they did eventually agree to it and added her to the study. And it took 2 years, but her genome result came back with her diagnosis. So 5 years in total it took to get Tilly diagnosed.
Can I ask what age she was when those first sort of missed milestones and symptoms presented?
4 months.
4 months. Gosh, okay.
Yeah, and it became quite dramatic. She all of a sudden just became completely mute. She couldn't walk anymore. Her motor skills were just really, really regressing. But still, the waits were ridiculous. Even when Tilly was diagnosed, I still had to wait another 11 weeks for her to start treatment. So it was just really long and protracted and so frustrating. I mean, I am a very strong-willed person, and I honestly believe that if I hadn't pushed and pushed and pushed, she would have just been landed with an epilepsy and global developmental delay diagnosis.
What do you think the key barrier was there? Like what's your feeling looking back on it as to why what you were saying was kind of going out into the ether and not being responded to?
I don't know. I think I was a younger mum, so I had Tilly at 22, and I think they just saw me as a silly little mum that was just worried about her baby because she had nothing better to do. And yeah, that I feel like I wasn't being listened to. I was always being told, oh, she'll catch up, that's normal. And it was a really, really difficult time. I'm amazed that I actually got through it really without any long-term effects, because I just felt insane half the time. I thought, is this all in my head? I'd have friends telling me that, maybe you are just thinking about it too much. So when she finally got that diagnosis, I wanted to print it in the newspapers. Yeah.
I think that's something I can very much personally relate to that. And it's something I've heard over again, is that it's so bittersweet, because on one hand, obviously you get that label and that news and it's utterly devastating. But then on the other hand, you're so conflicted because there is an element of relief, like, oh my,
Yeah.
it was something, I was right in a, I
Yeah.
wasn't going mad. So it's such a conflicting time, that, isn't it? And, that's such a lot to go through for anybody. But, how have you got through, have you had support? Have you, looking back now, have you kind of made peace with that phase of life?
Yes and no. I think it's definitely shaped how I am as a healthcare professional. So I'm a midwife as well. And it has always meant that if someone tells me they're worried about something, I follow it up and I see it through, because I know what it feels like to not be listened to and to be, oh, sorry, my phone went funny then, to feel invalidated. So, even if it's not a problem, at least look into it for them. Yeah. That's really, really important. I've lost my train of thought there, but yeah.
Thank you, Hannah. I think you speak for a lot of people's experience there, and I think we can all relate to that. And it's clear that, key signs were missed. So Vidya, if I can kind of jump to you for a minute, what are the symptoms and what should healthcare professionals and families, because families, of course, are the front line in knowing their children so well, what should they be looking out for when considering IMDs?
Yeah, as Jonathan, Hannah, and Rachel have rightly alluded, these disorders are very rare and can be quite complex. And so it's important to be aware and educate all of us and professionals and families looking after these children. The key symptoms are mainly if a child, I can talk about children because I'm a pediatric metabolic specialist. So if they'll have developmental regression, so as Hannah mentioned, forgetting what they have learned before. So previously they were able to walk and they are no longer mobile. These are key red flags to consider a metabolic disorder. Or if there's can be seizures which are not responding to the standard treatment. So for the GAMP deficiency, which Hannah was mentioning, they need a particular treatment. So they might not be responding to the traditional, the normal anticonvulsants. So it's not responding to the standard treatment, or if there's organ enlargement, which results in, the tummy looking a bit bigger, or they have either very small head or a very larger proportion of head compared to the family members. It's these symptoms in a child. And for instance, in children with urea cycle disorder or children who can't get rid of the ammonia toxin, so they can present with episodes of confusion when they have normal childhood illnesses. So it's important if they're taking longer time, they're very drowsy, or they have what you call as a cyclical vomiting. So they're presenting multiple times to the emergency department with this bizarre vomiting episodes, and it's happening many frequently. I think these are the symptoms to look for.
Is there a typical age of onset of these symptoms, or is it very varied across the?
It is quite heterogeneous. So there's early onset disorders and the late onset. It's completely to do with the amount of enzyme left to break down the ammonia. So it can be either sort of, very early on, soon after birth, or it can be as an adolescent or an adult. So it can be quite variable.
Okay, thank you. And Jonathan, obviously it's clear from Hannah's account that, Tilly was showing signs very early on, as young as 4 months. What is the role, if any, in newborn screening here? Is this a beneficial tool?
Yeah, definitely. So newborn screening can significantly impact the diagnostic journey of IMDs. So obviously you'll get that newborn screening test on either day 4, day 5 of life. You get those results back in a few weeks, and as soon as you get those results back, that's when you can start seeing not only is there any treatments out there, is there any sort of condition management out there. It's having that diagnosis can be very powerful to unlock other sort of avenues as well of support. So for example, even just connecting to us and we can offer support in that, but also just being able to have like work capability assessments. So like when you go for reasonable adjustments and stuff like that in work, they'll say to you, oh, have you got a condition? Oh, I've got something, but I'm not quite sure what it is. It's very powerful having that diagnosis and having that recommendation from the doctor that you need those adjustments. So, for example, newborn screening in the UK, it currently includes 6 IMDs and tyrosinemia type 1 has also been recommended. So that's been recommended by the UK National Screening Committee. And then that recommendation has been endorsed by Andrew Stevenson, so that's the Minister for Health and Social Care. So with this condition, that can be devastating if it's not caught early. That can lead to really early death. It can lead to disability. You need transplants and stuff like that. So through catching that early, you can prevent all that happening. You can just say, right, okay, there's this treatment's available. We've caught it. We're going to start the treatment, and then it then improves those outcomes, maybe prevents people having to get transplants and stuff like that. So obviously, these are positive steps towards improving outcomes for IMDs, because we can sort of see people accessing different things, such as specialist care as well, and accessing that widest care. So processes to review the addition of new tests do need looking at. Obviously, I think that's probably everyone sounds like a bit of a broken record at the moment, but to get actually that sort of condition added onto the newborn screening test, it can be a really long process, and it can be a lot of work for organisations such as maybe patients' organisations, for people pushing for it. And obviously there needs to be that stringent evidence review to protect people from harm, like of living with a condition where there may not be yet be an approved treatment, but while there may not be curative treatments, this diagnosis may help people's lives in other ways. For example, access and support, enabling people to access communities so they can sort of say, I've got this condition. It just having that interaction with other people affected by it, condition management, being able to have benefits and stuff like that. So for example, with Hannah, if your child had received that newborn screening and you've had that straight away, you wouldn't have had all this, oh, am I crazy? All of these sort of thoughts going through your head. It would have been like, this is the condition, this is what we're going to do for you. We're going to connect you to other people affected by that. And the thing is as well, before you've got that diagnosis, you get this people saying, oh, that parent is they're just a new parent kind of thing. It's that whole narrative. And as soon as you receive that sort of diagnosis, the whole narrative shifts, and it's, oh no, you're a patient expert now. Can you be invited along to this? Can you sort of speak about this? And it's like, you've always been the expert because you've dealt and looked after that person, or you've lived with the condition potentially. So yeah, I do think newborn screening can really impact the diagnostic journey. It's a very important tool, and it definitely does need looking at.
And it feels like there's not enough weight given to that element of, like you say, the importance of the support. And even if there isn't an approved treatment, there are still lots of things that can be put in place as a result of that. And that's not really being given enough weight within newborn screening. And you mentioned that another number of IMDs are currently on it, but how many of those would fall outside of that and would have no coverage with newborn screening at the moment?
So how many conditions do you mean? Like how many inherited metabolic disorders?
Yeah. So how many of those are not being caught by that at the moment?
So IMDs are a huge collection of rare conditions. So it really varies within the literature, but it's definitely over 500 conditions. And
That's right, yeah.
considering that there is currently 6 and one's just been added, and I think the last ones were added a good few years ago now. So for example, people have had to continually submit evidence so that HT1 gets added to the newborn screening panel. If we have to do that for everything, we'll never get anything put anytime soon. So I think looking to other countries as well, looking at their evidence, seeing what they've sort of developed. I know that there was a good study done over in Germany that was used to support the HT1 sort of being added to the newborn screening panel. But I do think that we need to look externally and sort of look at what evidence they've got rather than trying to regenerate evidence in the UK. It's like, is the good evidence out there? Can we use it? It goes back to that thing of collaboration and sort of working with those clinicians to see if we can sort of expand that panel.
And is the picture, I don't know whether you know this, but is the picture different across, Europe and worldwide in terms of that? Because, 7 out of 500, over 500 seems a really low, a low sort of hit rate. Is that number different globally? Are we dragging our feet in that regard in the UK?
So, I couldn't say for certain with inherited metabolic disorders, but I do know that, for example, in America, there's over 50 conditions screened on that newborn screening panel. Italy, even, for example, I recently did a case study on the Philippines. The Philippines is a developing country, started the process of just developing newborn screening as a pilot project in 1996. and then they have now got a larger newborn screening panel in the UK. And I'm like, we are supposedly a high-income country, one of the best healthcare systems in the world with all these amazing expertise. Why are we lagging behind other countries?
And
Need to-
Mitra and Jonathan, I would like to add on just on the newborn screening. Our in newborn, the NHS England and Public Health England are piloting whole genome sequencing for all newborns. It's going to start soon, and they're planning to screen for majority of the metabolic disorders. So it might shed some more light. And we've been involved in developing referral pathways right from somebody's identified as a positive screen, what to do and when to refer. So that's coming up in the next few months. So it might help UK Newborn Screening Committee with some more information.
That's it.
Yeah.
Yeah. Is that the generation study that you
That's right. The generation, whole genome sequencing, which they're planning to screen all babies born in the UK for we've listed around, I think, 70 or conditions.
Yeah.
So we'll be looking at, it starts with looking at genetic changes in the newborn blood spots, and then confirming the condition with that, and then treating.
That's it. It's a really positive sort of opportunity, and I do think that it's got really big possibilities. And I think as positive as it is, I know that it's sort of at the moment it is a research project, and whilst it's really positive kind of thing, we do need to sort of make sure that we're also keeping our foot on the gas for expanding that screening panel, and sort of maybe exploring both avenues. And then once we've got the evidence from that generation study and we can look at that and say, is that maybe the best way of going? Then we can start to go, okay, let's implement that, because that could be a really positive development, definitely.
Brilliant, thank you. And Hannah, aside from, as Jonathan mentioned, the kind of the support and the lack of the more distressing, shall we say, emotional effect of being ignored through that lengthy process you had, do you have a feel for how, if there had been newborn screening, that might have impacted your ability to care for and manage Tilly in her disease?
Yeah, so when you asked me earlier if I had made peace with those 5 years, the big thorn in my side is knowing that if Tilly had been screened at birth, she would be developing completely normally now. So she is, so she's 11, she's got a severe learning disability, she is nonverbal, she is very, 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 very behind. And if she had been diagnosed and treated from birth, she would be developing normally, which is so it was wonderful getting her diagnosis and knowing it had treatment, because it has made a huge impact, and she can now communicate using I mean, she makes up new ways of communicating every single day. She's very funny, and she can write her name now. Yeah, going from being told, it's a degenerative disorder, she's just going to get worse, to knowing it had treatment. I felt that day I won the genetic lottery, and I used to go to sleep at night hoping that she'd still be alive in the morning, because her epilepsy was so bad. So treatment has meant that her epilepsy is now very much under control, so it's very much positive in that regard. But yesterday I was at my son's Easter concert and looking at her year group and thinking she should have been there. If she had been diagnosed on day 5, or in those first even couple of years of life, or even if she'd been diagnosed when her genome was sequenced 2 years earlier, she would have been so much more than she could be now. So newborn screening is so important, and it's something that I'm really, really passionate about. I mean, I was taking a Hilbrick test yesterday, talking to the woman whose baby I was taking it from, about the generation study and the impact of what we don't really do with newborn screening, because the amount of conditions that we screen for in this country is pitiful, and it's embarrassing. I mean, hearing that we're worse than the Philippines is, wow, it's just something, isn't it? So newborn screening would have completely changed our lives. I wouldn't need, DLA. She wouldn't have to go to a special school. She would just be a normal 11-year-old who takes certain supplements and avoids high protein food, because her condition is so treatable. I know many families now that have got siblings with GAMT, and the ones that were screened for at birth because of their siblings, they live completely normal lives. So seeing it and knowing that is difficult, and it took me years to, you know, make peace with how different life could have been for her and for me.
Well, and it just makes it all the more important. You know, I think that's why there's so much value in people like you sharing that story, because you can say that so with such a depth that it's impossible to convey to those healthcare professionals that are busy about their day, you know, seeing people in 10-minute increments, but actually, you know, the impact of that landing on someone and realizing that really is the impact of you not taking the time to stop and listen. So I really appreciate you sharing that, Hannah. Thank you.
No problem.
And it kind of goes on to that importance of neurologists in this particular part. So Rachel, can I come to you a little bit just to kind of talk about, you know, what is the role of a neurologist within treatment and management of IMDs, and, you know, how important is that given the context of everything that's just been said there?
No, absolutely. I mean, I think the roles of the neurologist, and let's not forget the pediatric neurologist as well, are absolutely critical. And I think, you know, Jonathan and Hannah sort of reinforcing the sort of limitations currently of newborn screening, in the absence of something that can pick these things up an awful lot earlier. A critical role that a neurologist has is really to have a thought that actually this might not be as straightforward, looking at the sort of neurological symptoms that a patient is presenting with, that actually they should think beyond what is, maybe it's just epilepsy, and we won't worry too much about what the parents saying because they're sort of overthinking a bit. They haven't seen this before. I have. It's really taking their time to fully assess that patient and to take on board what the parent is saying, because they know their child better than anybody else, and so to be able to communicate that and really take that on board, and to undertake those comprehensive investigations that could potentially lead to an early accurate diagnosis and avoid that odyssey that patients and their families and caregivers go through before an accurate diagnosis is made would be essential. So then the earlier the diagnosis, even in the absence of a targeted treatment, actually could lead to an intervention that may slow the progression of the disease. So 100% they're critical from that point, as well as having that sort of index of suspicion, as it were. They can also refer on to specialists who are experts in this specific disease that has been identified, so that obviously they get the best care possible at the earliest time possible. And beyond that, I think the as you sort of alluded to, or people have alluded to in discussions today, it's knowing what it is, having a name to put to it is also critical, and that not just gives you a name in you know, just in its purest sense, but it also allows you access to then the additional support and the support network that may be available, which is critical to help people in the short term to come to terms with the diagnosis, but also help with that ongoing support as they go through the journey of the disease through the rest of their life. So that's sort of the primary, is identifying the condition, and then obviously secondarily, obviously we've said a lot of the sort of manifestations of these conditions are neurological. They have an impact on neuromotor skills and on cognitive development of infants and children. And so the neurologist has a key role in assessing and making interventions that can reduce the burden of those symptoms, particularly when they can't be managed by sort of active treatments to manage the disease in totality. And so I think they're an essential part of just not just the diagnostic piece and the early stage management, but also forming part of that sort of critical multidisciplinary team that is essential to managing the sort of the totality of the patient, and not just little parts of the disease in itself. That we need to recognise the patient is one individual and not just a series of different symptoms to be managed by different specialities. And so that the sort of coordination of care and the rolling coordination of care is essential, not just at the early stage, but to support patients as they grow through their life journey as well, going through from childhood to adolescence, and then through to potentially to adulthood and the need for adult care. So ensuring the sort of consistency of treatment and consistency of knowledge of the disease shared, so that the patients and their support network have the sort of optimal support that they possibly can, not just to improve the experience, but the outcomes for the patients in the long term.